Deep within the human pelvis lies a highly sensitive crossroads. The anorectal region is a dense network of nerve endings, vascular structures, and muscle. Social stigma often leads patients to minimize or withhold details about symptoms in this area, delaying medical consultation until the condition becomes severe. Surface-level symptoms, such as mild bleeding or persistent discomfort, can originate from vastly different pathologies, ranging from minor irritation to internal structural ruptures or occult carcinomas. To understand the diagnostic challenges of this region, we will examine three distinct conditions: acute physical trauma, subacute mucosal inflammation, and chronic intractable irritation. Because different conditions share identical presentations, clinicians must maintain a high index of suspicion to distinguish between a temporary nuisance and a life-threatening surgical emergency. Acute trauma to the rectum and anal canal represents the most immediate threat in this region. These injuries often result from severe high-impact falls, penetrating wounds, or complications during medical procedures like enema administration. The primary surgical objective is to determine if the rupture is intraperitoneal, meaning it has occurred above the pelvic floor, or extraperitoneal, occurring below it. An intraperitoneal rupture allows waste to breach the sterile abdominal cavity, risking sepsis. Management requires an emergency laparotomy to suture the perforation and clear contaminants. To facilitate healing, a protective colostomy routes waste through the abdominal wall, bypassing the injured tissue entirely. These physical injuries require rapid mechanical intervention and waste diversion to prevent lethal complications from systemic poisoning. Moving from structural trauma, we encounter proctitis, an inflammatory condition of the rectal mucosa that carries its own set of biological risks. Proctitis is characterized by tenesmus, an intense, painful, and often unproductive urge to defecate. Instead of stool, the patient may pass blood, mucus, or pus. Sigmoidoscopy is necessary to visualize the extent of the inflammation. The exam typically reveals a swollen, reddened mucosal wall, often accompanied by small ulcers. Clinicians utilize cultures and smears to identify the specific pathogen responsible. Potential causes include dysentery, gonococcal infection, or even secondary tuberculosis. During the examination, biopsies are taken from any ulcerated tissue. This is a critical step to ensure that a localized inflammatory mass is not actually a hidden carcinoma. Effective treatment of proctitis is entirely dependent on identifying the microscopic origin of the inflammation. The final stage of the spectrum is Pruritus Ani, an intractable and relentless itching in the perianal region. While often dismissed as a hygiene issue, chronic itching frequently signals an underlying systemic or surgical pathology. This diagnostic tree illustrates the symptom's clinical breadth. Systemic conditions like diabetes or parasitic infections are evaluated. The surgical branch reveals severe possibilities, where itching is the primary symptom for malignancies. Resolution requires treating the specific disease at the root. Pruritus Ani demonstrates how a single, persistent symptom can serve as the clinical endpoint for a wide array of disparate and sometimes life-threatening diseases. Our analysis has spanned from urgent surgical repair of a ruptured abdomen to the identification of microscopic pathogens and the screening of occult melanomas. The anal-rectal region demands a wide range of clinical expertise, integrating trauma surgery, infectious disease, and oncology. The lower gastrointestinal tract functions as a sensitive indicator for both localized injuries and broader systemic health. Overcoming social stigma is essential for early diagnosis. Embarrassment often prevents the timely investigation required to identify dangerous conditions. A professional medical evaluation is the only way to accurately distinguish a minor irritation from a condition that requires immediate, life-altering intervention.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.
At the very base of the human spine lies the Sacrococcygeal region. In early development, this location acts as a biological crossroads. This area houses the primitive knot, a cluster of totipotent cells. These specialized units possess the biological capacity to form every distinct tissue type in the human body, from rigid bone to soft muscle and skin. Under normal conditions, these cells complete their role and stop dividing. But if these signals fail to terminate, the cells multiply into a disorganized growing mass. The result is a Sacrococcygeal Teratoma, seen here as a large swelling protruding from the lower back of a newborn. It is the most common tumor found in neonates. Because this mass originates from totipotent cells, it retains the ability to construct complex anatomical structures, sometimes growing rudimentary limbs like hands or feet deep inside the tissue. If left attached, the physical toll on the infant is severe. The massive growth causes ulceration, blocks the rectal canal, and risks secondary infections and malignant transformation. Immediate surgical excision is the only way to stop the mass from obstructing the rectum or becoming fatal. This cross-section shows the cramped geography surgeons must navigate. The tumor is wedged tightly between the sacrum and coccyx in back and the rectum in front. Looking closely, the mass is firmly attached to the coccyx and occasionally anchors into the sacrum. Facing the risks of infection and malignancy, surgeons perform the excision as soon as the diagnosis is confirmed. The procedure starts with a longitudinal elliptical incision. Surgeons lift the skin and subcutaneous layers to expose the dense bulk of the mass underneath. From there, the team must separate the entire volume of the tumor from the surrounding healthy structures. To prevent the tumor from growing back, the surgical team must also remove the coccyx and the attached portion of the sacrum, extracting them along with the mass. Success requires dismantling the skeletal anchors. Once the skeletal anchors are cleared, the team shifts focus to the front of the mass for the anterior dissection. This spatial map highlights the operation's most dangerous phase, working against the outer rectal wall. A single slip can cause catastrophic digestive injury. Sometimes an abnormal fistulous connection links the tumor to the rectum. This tract must be excised and meticulously sutured closed. Executing this closure perfectly is vital, as it often spares the infant from needing a colostomy. With the tumor and skeletal fragments gone, surgeons drain the dead space left behind before closing the skin. A final pressure bandage is applied to secure the region while it heals. Surviving the excision depends on this millimeter-perfect navigation around the digestive tract, transforming a massive anatomical hazard into a safely closed system. While the neonatal teratoma is massive and obvious, this same region hosts a variation that can remain hidden for years, the post-anal dermoid. Geography dictates the danger here. On the left is the outward swelling of the teratoma. On the right, the dermoid cyst sits in the same region but is tucked into the hollow curve of the sacrum, behind the anal canal and rectum. Because it is shielded by the bone and tucked behind the digestive tract, the cyst can sit dormant for decades, causing no symptoms and remaining unnoticed into adult life. Eventually, the cyst may expand. Because it is trapped in the narrow space between the bone and the rectum, its growth often first manifests as difficulty in defecation. If the cyst becomes infected, the physical consequences are severe. The infection carves a sinus tract, a tunnel of diseased tissue, from the hollow of the sacrum all the way to the exterior skin. Because the cyst sits directly against the rectal wall, a physician can detect the soft swelling through manual palpation during a physical rectal examination. This internal check is the only way to feel the mass while it is still hidden behind the bone. These remnants of our earliest development possess immense power. Managing them requires either immediate neonatal surgery or the clinical vigilance to uncover what stays hidden in the dark corners of human anatomy.
Imagine the pelvis in lifelike 3D. You zoom past the anal canal into the postanal space, where a smooth, encapsulated cyst sits behind the anus. Labels appear: anal canal, levator ani muscles, and the coccyx. Inside, keratinous, hair-like, sebaceous debris fills a congenital pocket, ectodermal tissue trapped during embryonic development. Over months or years, the cyst slowly enlarges. You can see the soft tissues bulge, swelling when sitting, aching pain, and sometimes recurrent infection. If drainage develops, a tender abscess may form, or a small sinus can discharge fluid. Pain may wake you at night, and sitting long can feel like a sharp pressure inside the area. Now the animation shifts to MRI and CT. A well-circumscribed retroanal cystic lesion, clearly separated from surrounding tissue. Finally, surgery, a posterior perianal approach, careful dissection, and removal of the intact cyst, no rupture. The wound heals. Complete surgical excision is curative and prevents recurrence.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.